This is a podcast about the power of lived experiences, about how stories can shape more human-centered systems, spaces, and services.
Each episode, we sit down with people who are challenging the status quo, leading with empathy, and helping others through their work and their stories.
We're Farah and Megan, and this is Collected by Unum Co. Welcome back to Collected. Today we're here with Dr. Saskia Sivananthan, who works at the intersection of brain health, policy, and care. She brings a wealth of deep experience in dementia and really what it means to think about our brain health. So we're excited to dive into it.
Yes, thank you for joining us today, Saskia. We're really excited to have this conversation. And I think the first real question we have is what drew you into being so interested in brain health?
Well, first of all, thank you for having me. It's a pleasure to be here. So I thought about this because I knew you were going to ask me this question. And I went back a little bit and I realized there were a couple of really big inflection points in my career that shifted me towards this space. But really, I was a super curious kid and probably a really nosy kid as well. I feel bad for my parents because I was always wanting to know why and how. And that curiosity, though, kudos to my parents, they really nurtured it. So they didn't shut it down, which sometimes you want to do with kids. You're like, just stop with the 300 questions.
Yeah.
They just kept answering them and allowing me to continue that path. So it just research and the brain was always fascinating to me because when you think about all the ways in which we function, how we identify ourselves, all of it resides within this amazing control system that we don't really know that much about considering what it does. So neuroscience and the brain health was definitely going to be where I was going to go. But I was going really down research in a very basic research way, like understanding the functions and the pathways. But while I was doing my grad studies in Montreal, I was looking for an apartment and found this gorgeous apartment. And I didn't even know how I could afford it because it was just unreal for the price. But then it turned out it was rent controlled in a seniors building. And they just happened to have opened it up now to the public. So I was like one of the first people under the age of 65 in this building. And my neighbor was a gentleman named Vince, who had mild cognitive impairment. He lived alone. It eventually progressed to dementia. And I became his proxy caregiver.
Wow.
And I think and I would never have identified myself that way, I think. But in hindsight, I was like helping pick up his prescriptions, getting his groceries, visiting him in the hospital, making sure that he was tracking all of his, and that all the things that you end up doing kind of as a caregiver. And seeing through his eyes how he was interacting with the health system and all the huge gaps in the system really changed how I saw and what I wanted to do. I wanted to have a more immediate impact on how people experience care, especially dementia. And so I did wrap up my grad work and then went back to school again later for research in health policy, like getting those tools and understanding them to be able to make system change. So that was one of the really big inflection points. The second, very quickly, is that I have a very close relationship with my grandmother and my grandfather on both sides of the family. And so I think recognizing the value that older adults bring to your life and the experiences had always been there. Like my earliest memories of my grandmother and her singing and teaching me, and those have just carried through. And again, how I think we at Brainwell think about older adults generally, but also just about patient engagement and centering on the human experience.
And that leads nicely into Brainwell. So you started Brainwell just recently, a year ago. Can you tell us a little bit more about what you're doing with Brainwell and how it's different from what you were doing before?
Yeah, for sure. I think we wouldn't have been able to start Brainwell if Alexandra Wade is my co-founder, if the two of us hadn't had the experiences we had had before. So I had worked at the World Health Organization, the Alzheimer's Society of Canada, as well as in different health systems previous to that. And so that really gave me a better understanding of the inner workings and at different levels, international, national, local. Alex is a scientist, a researcher by training, and she's worked in different sectors. So dementia was not her primary sector. She's worked in cancer care and others. And so both of us kind of coalesced at this point where we were frustrated because we were seeing such good, high quality evidence around what is good brain health, around what good quality of life looks like and can feel like for people living with dementia and their care partners. And it was just not happening in the health system. The experience, the average experience for someone who's living with dementia, just getting diagnosed and moving through the system, is abysmal. Like it even in places, urban environments where you do have access to, specialists and some programs and services, we just don't coordinate that care. We put so much of a burden on the caregivers and families to figure it out. And we don't value the person, the person who's living with the disease. So at Brainwell, our big focus is on helping shift systems to coordinate care for dementia at the federal level and implementing it at the provincial level so that it starts becoming a pathway that you can see and feel in your care day to day.
So needed.
Yeah, absolutely. I mean, so much that you have shared in these few short minutes have sparked so many questions for me. And just, you started talking about your experience both with Vince in the seniors apartment and residence that you lived in Montreal, and then your own experience with your grandmother. And I think that so much of just the way we live today excludes us from those kinds of, multi-generational families that many of us grew up living in. And I really would love to know more about, what you're seeing from you talked about the caregivers and the family members that are really impacted by dementia as they care for their loved ones. Like, what are some of the things that people, are struggling with the most when it comes to that kind of care, and even recognizing, that there could be a problem with their loved one, their parent, their grandparent?
Oh, such an important question. I think especially with a disease like dementia, which the symptoms of which are not always super obvious. There's not like a hard switch that happens, right? It's very progressive. And people think of dementia as just memory loss, which progresses over time. But there are other symptoms that come up first, right? Personality changes. Sometimes people become more withdrawn, language difficulties and disorientation. One of the things, we have this wonderful social media and partnership manager, Katie Condorosi, who works with us, and her father was diagnosed with young onset dementia.
I saw this
19
reel that you posted.
That's right. And she tells this story that for her was the real trigger point around realizing, hold on, this is something else is going on. So her dad was like the glue of the family, is how she's always described him. He did everything from chauffeuring to cooking to, and he, over a period of 1.5 to 2 years, started becoming more withdrawn, was having difficulty at work. And the big point for her was she'd gone to visit a friend and he was supposed to come pick her up. And this is a friend she's visited multiple times, doesn't live very far away, and he never came to get her.
Wow.
And then when she called, he said he didn't know how to get there and that he just, he got confused. And that was a very hold on, what's going on moment for her. And then she said, as they started actually looking and paying attention, they realized, there were these mood changes, difficulties with managing finances, they just hadn't picked up on. So there are these smaller changes that often it's the caregiver or the family member that sees first. And the thing about dementia is, I think there's two things. One, that it is progressive, which means that eventually the person can no longer take care of themselves. So you're talking about 40 plus hours of caregiving a week full-time job, 7 days a week, often all day, because there are disturbances at night that the person with dementia experiences too.
Right.
But the second thing is that dementia is life-limiting. You can die from dementia, but the average age that a person lives for about 8 years, right, with dementia. This is not a short-term kind of disease.
Right.
So imagine being a caregiver who has to care for a person this long, who's not being given the training, who's not getting that kind of ongoing check-in and support to be able to manage this kind of care. It's enormous. And so that's really what we heard a lot from caregivers. Again, that need to have coordination through the health system. And we've talked about this before. Cancer and stroke are really good examples in that they are diseases that have had huge impacts on society. They're like public health crises in a way when they first were being recognized.
Right.
And we've progressed so far. It's not perfect, but
Right.
we really have progressed. For cancer and stroke, when you're diagnosed, first the diagnosis is much more efficient and effective. Whereas, for either of those diseases, the benchmarks for diagnosis are days to months.
Right.
Cancer, dementia is 21 to 28 months. We're talking
Wow.
2 years.
My goodness.
On average.
I thought you were going to say
depending on where
days.
you are. No.
That's crazy.
That's how, and then after that, there's really not a clear coordinated way. So most people aren't getting follow-ups
Right.
for another year or so.
Yeah.
They're not really told how to navigate the health system. We don't look at rehab care. We don't look at the person,
Right.
the caregiver and the person, and say, how can we help you to retain as much of the skills you have, which we do for cancer and stroke. We don't do
Right.
that for dementia.
Yeah.
So these are some of the really big pieces that need to change. We have good evidence to change them. We just have not implemented them.
Sorry, were you about to say something?
I know I was just, I love that you brought up the examples of cancer and stroke, because I think that there's been so much awareness, advocacy at the system level, at the policy level for both of those, I guess, umbrella areas of disease, right? And I would love to know your perspective on this, because I think when we think about, dementia and even how dementia progresses, right, from mild cognitive impairment through dementia, potentially Alzheimer's disease, we're talking about an organ which is essentially the motherboard of the human body. Why do you think it is that we just don't pay attention to changes related to our brain health, that there's not enough focus on it from a public awareness perspective? Like, from your experience, what do you think are some of those reasons?
I think you actually articulated it perfectly, which is because the brain is the motherboard, the idea of not having control over that is extraordinarily scary. Right? Because we center who we are based on on how we are able to respond and react, and our identity. Everything is tied to this.
Right.
So the stigma of, hold on, I cannot control this anymore, is really so scary that most people don't want to talk about it or deal with it. So I think that's a key piece. The second is that when you think dementia more broadly, it tends to impact people who are older. And again, we have a fair bit of ageism when we come to thinking about what value there is towards the later stages of our life.
Yeah.
And we tend to think of things from a very economic perspective. And you're not economically productive anymore. You're not giving and producing in that later stage. You're seen as taking from. So there's another reason I think that contributes to it. But the third is really, I think, brain health broadly. We've only understood more about the risk factors related to brain health really probably in the last decade or so. Before that, most of it was centered around our body and heart health.
Yeah.
But now we know there's such a strong linkage to heart health and brain health. That kind of awareness is really starting to become part of the broader consciousness, just like mental health broadly is.
Yeah.
Yeah, you kind of asked my question in a way. I was going to ask you, like, do you think that there's not as much emphasis on dementia because once you get that diagnosis, it's kind of like a lot of people see it as an end.
Right.
Yeah.
But I remember when we had a conversation earlier and you had said something like changing the way that people perceive that diagnosis, it's not, you're not done. You can still be very active, and you can still, like, you still have a lot of life left. And there's even patient advocates that you work with that have dementia that are still clearly able to advocate on behalf of other people and work. And I think that's a real big, like, stigma that people have around dementia. And I love that you're changing that, and just the way that you even speak about dementia, it's very refreshing to hear that it's not like your life is not over the minute that you get that diagnosis. So yeah, I'd love to hear more about the whole idea of what that could look like for somebody when they first get that diagnosis, and how they can reshape or shift how they're, I don't know what I'm really trying to say, but
no, I get
yeah,
it. I do get it, Megan. Yeah, no, because I think your question actually ties to also how some physicians see dementia.
Right.
Because it's something like 35 to 40% of physicians feel comfortable even diagnosing it.
Oh, wow, that's so low, right?
It's low. Because if you're comparing to other countries that we aspire to be and have similar systems like Denmark, Sweden, the UK, it's in the 68 to 75%. So we're quite significantly lower. But part of that reason, and we've surveyed physicians, family physicians, to understand it, is there's a couple of things. One, there's sometimes like health professional stigma. Like they also don't think there's much that they can offer or that a person can offer with dementia. So they delay the diagnosis. The person themselves doesn't want to hear it, and neither does the family. Right. And that relationship between your family physician and the patient is so important that sometimes to preserve it, there's a delay or they won't provide the diagnosis.
Absolutely.
But the big piece is what next? What do you do next when you give someone this diagnosis? Because it is a label that can sometimes have huge repercussions, right? Especially with driving. Like that's the number one question that comes up for us. We used to run a helpline when I was at the Alzheimer's Society of Canada. And one of the big questions is, you know, if I get diagnosed, did they take my driver's license away? Because that's tied to autonomy. It's tied to independence, all of those pieces. So I think when we think about going back to your question, why, you know, how we perceive dementia, because of that stigmatization around it, and because we don't offer rehabilitative care. And that's what we really want to see happen with dementia. Yes, you want the care to be coordinated, but that includes offering the person rehabilitative services, which again, we do for the other key diseases. Because rehabilitation doesn't necessarily mean reversing. And I think we think of it as like reversing you back to your baseline, but that's not what it means. It can mean helping sustain for as long as possible the skill sets that you have. And one of the key factors, risk factors actually, in brain health to developing dementia is social isolation.
Right.
Withdrawing from society, not engaging.
Right.
And what happens when you get a diagnosis of dementia? A lot of people socially withdraw because they don't know how to explain it to others. They're still dealing with it. They're grieving over what that diagnosis means. And that makes it even worse because we're not supporting and providing that support. So I want to give you two examples. The first is a lady named Phyllis Fair who lives with dementia, and she works with us. And in fact, we submitted a report to the UN Committee on the Rights of People Living with Disability, because dementia is considered a disability in Canada.
Oh, I did not know that.
Not a lot of people do. And in fact, it means then accessing disability supports and financial and tax breaks with disability that you can access when you have dementia. And so we submitted a report to the UN highlighting some of the gaps with dementia. Even though it's considered as a disability in Canada, it's just not supported and made accessible the same way.
Okay.
So Phyllis helped write the report, and then Phyllis went to Geneva as part of the Canadian contingency, and she advocated in front of the UN committee. And because of her advocacy, Canada received a special recommendation from the UN asking it to implement the dementia strategy, to have targets aligned with it and to have funding aligned with it, which would not have happened if Phyllis had not gone.
That's right. That's incredible.
And that's Phyllis, and that's always been the way she's worked. And we supported and worked with her, leaning on her expertise with lived experience, and she leaned on our expertise around how to frame that report and to write it. But the second example was around just how important storytelling is.
Right.
And when I first got to the Alzheimer's Society, I remember thinking, well, a couple of things. One was also just that we were not hearing from diverse communities. They were not interacting with us as part of the programs we were offering, and we weren't hearing how they were dealing with dementia. So when we started thinking about how to report on this and how to talk about it, it was storytelling, because that's so powerful in all communities.
Yeah.
And so the second report we released, The Many Faces of Dementia, is all about the stories from communities, putting faces to names and hearing from people who have lived with this disease and have changed how they see that disease that yes, it is life-changing for them, but that it is not the be-all and end-all.
Right.
And that there are ways in which they are continuing to engage and give and support that are hugely powerful and meaningful. And that report is one of the most downloaded and accessed reports because of that storytelling.
Yeah.
That's
Interesting.
amazing.
Yeah.
Something you said a little bit earlier on about other countries that are similar to ours from a system perspective. I think Denmark and the UK, perhaps. I guess maybe my first question is, how does Canada fare when we think about our, I don't want to say like dementia care, because from what we've learned so far, there is not really even a clear pathway to diagnosis. And then there's not a clear, coordinated care pathway once somebody is given a diagnosis. So yeah, how do we compare relative to other countries? And given that there is no cure for, dementia or Alzheimer's disease, where do we fit in the global picture?
That's definitely a big piece, the lack of a diagnosis. The lack of a treatment, a treatment that can change dementia or Alzheimer's. So there are treatments, but they're about modifying more the symptoms than the underlying disease.
Right.
Now, there are a first class of drugs that may eventually make it through to the health system, but they are just a first class and they only make a minor difference, if any, depending on when you're diagnosed and all of those pieces. But I would point to other diseases, again, cancer, HIV, diabetes, that didn't have those breakthroughs, but started shifting how we talked about the disease, how we thought about ourselves living with those diseases. And eventually that allowed for the sorts of treatment changes that could come through. We also know that lifestyle plays a big factor with dementia, even when you're diagnosed with dementia.
Okay.
So people often think those risk factors like getting your hearing checked, social isolation, better sleep, cognitive engagement, that those are the risk factors specifically only related to the development of dementia.
Right.
But actually, even when you have dementia, those factors and making those changes are huge. Diet and exercise by far, actually, and very specific types of exercises have been shown to really impact and slow that cognitive decline. But back to your question about how does Canada fare, we wondered this as well. So we did.
I'm almost afraid of the answer.
Yeah, it's not a good one. So Canada has a national dementia strategy.
Yes.
We released in 2019, and it's a fantastic strategy. But it is a strategy that doesn't have a lot of teeth and hasn't been implemented really in a coordinated way when it comes to the care piece. And so when we looked at other countries, there are 11 other countries that compare to Canada in that they're federated models. So it's not all centralized. You've got sort of the decentralized operational approach. Similar resourcing to ours, and then a public payer system. Those are sort of like the three big pieces we looked at. Canada is like middle to the end of the pack when you're looking at scoring across them, because there are 6 sort of key ingredients or success ingredients that other countries have implemented that allowed them to move those strategies into sort of concretely care.
Okay.
First is clear governance, that they're very clear about who is responsible for what, where are the lines of how that gets operationalized. They resource effectively. So that's the second. It's the money it's not about just the amount of money. It's about how that money is allocated and spent. They have very clear measures. They have KPIs, they have targets. And again, the ones that do really well have patient-oriented outcomes, which is very similar to what cancer does, right? It grounds it in what the patient is reporting is important to them, and then the data to support that. And then monitoring and reporting on it publicly, like holding themselves accountable and holding the other shareholders accountable.
Right.
And Canada does not do great on those pieces when it comes to dementia. But again, we have rooms, we have models to be able to improve.
Right.
There was this one example that I had been thinking about that I wanted to bring back, which doesn't necessarily totally relate to your question, but have you heard of dementia-friendly cafes and restaurants?
Yes.
I just started recently hearing
about those. So I think they're kind of popping up here and there here in Canada, but it really has taken off in countries like Japan, which has like a super aged population, and they don't have enough caregivers to be able to support caring for this older population and a high proportion of people living with dementia. So they have, for example, a couple of restaurants that are called the restaurants of, I think it's called missed opportunities or misplaced orders, because it's run by people living with dementia.
Okay.
Come to take your order.
Right.
And then you might not always get what you ordered, but you will get something that you will likely enjoy. And often they'll sit down and they'll chat with you, and you'll hear stories about what they've done, who they were, and what they're doing now. And what that really does is reduces the stigma around this disease. Because there was a public health survey that was done in Canada, and I think it was something like 60 to 70% of people were kind of uncomfortable talking with someone who has dementia, because there's this stigma around, I don't know what to say or how to deal with that.
They usually have a lot to say.
They have a lot to say, and really amazing stories and experiences. And they're very present too, I find, because especially with dementia, you need to focus on the present with the person and what they might be experiencing. And so this restaurant and these cafes really help you to get firsthand exposure to that, to reduce that stigma of it, but also to see the potential of what living with this disease is like. So I love those ideas.
I love that.
Yeah, that's amazing.
Really incorporate that into our communities more broadly.
Yeah. I've seen that in a grocery store model. I can't recall the country, but where there are certain hours of the day where they invite, seniors groups or homes that, have people living with cognitive impairment, and they kind of have cashiers or people present there who can just engage in conversation with people, and how it really, to your earlier point about the risk factor of social isolation, it really helps to, ensure that that's something that these people don't have to live without, right?
Exactly. Yeah, exactly. It's just a slower checkout aisle, or the person didn't bring their money because they might have forgotten, and that's okay. There's a way to track it and to deal with it. And just that engagement that we love and need as humans broadly, but especially need for our brain health.
Yeah, when I was doing my undergrad, I worked at a long-term care facility in their rec program. And honestly, like, I had the best conversations with the patients that were there. And it really opened my eyes to how stigmatized dementia is, but not just dementia, the term in general. And I want you to talk about that too, because I think there's just a lot of not misinformation, but just not a lot of education out there where people understand, like, dementia does not equate to Alzheimer's.
Oh, right.
You know, you think like, oh, dementia is Alzheimer's. No, dementia is the umbrella, and there's like, well, you can say how many diseases are under that, but like I had no idea.
No, that's
like even to work on like destigmatizing a diagnosis of dementia is like destigmatizing what the actual disease is. So could you talk about, like, there is not just Alzheimer's, but there's like bulbar.
Yeah, there's actually over 100.
Over 100. Okay, I was gonna say 20, but I'm like, I don't know.
No, over 100, and there are reversible dementias.
Oh, okay.
There are, and there are some dementias that are triggered due to deficiencies, and so that's part of the reasons why they can be reversed, especially in older adults. But there's also different ranges of dementia. So Alzheimer's disease is the most common form of dementia.
Okay.
And so the way I say it is just like cancer is an umbrella, and then there's breast cancer, lung cancer, all these other types of cancers.
Right.
Dementia is the same. Alzheimer's is the most common, followed by vascular dementia, which can usually happen after a stroke. There's frontal temporal dementia, which impacts the frontal temporal lobe of the brain. And so the symptoms are different. The trajectories are different as well. And it also tends to impact people who are younger, in their 40s or 50s.
Okay.
There's Parkinson's-related dementia. There's a huge range, for sure.
There's like
and
hallucinations.
Right. There's delirium that can occur with it. With frontal temporal dementia, for example, memory loss is not the first symptom. It's more language and personality changes. So again, and then that trajectory is different. It can be shorter or longer. With vascular dementia, for example, if the person has a series of strokes, then the decline, instead of being sometimes a slower decline, can be a sharper drop, like a stepwise drop. So like, again, we should all be educated in at least understanding that there are different kinds, and therefore the way we treat them should be different.
Right.
Yeah.
It's not really how we approach it. But I wanted to go back to your point about long-term care. I worked in long-term care as well. I used to volunteer and I used to play the piano when I was younger. And the best audience to date that I have ever experienced have been residents of long-term care.
Yeah.
They would like get up and dance and sing. They'd request songs, and we would often stay like an hour to 2 hours after the whole concert just to chat and have like tea and cookies. And again, it's like when you live through that, when you experience that, is when you recognize how stigmatized we've made this disease and we've made that stage of life. And sometimes with long-term care especially, we can make them so isolated because we kind of put people in a bubble and move them away, and then we don't see or hear from them.
They're in that home.
That's
they're
right.
there.
And that's there, and then I don't need to I don't really have to think about it.
Yeah.
And so that's another big piece that needs to change, because during COVID, the highest number of deaths were in long-term care, and up to 80% of people living in long-term care have dementia or cognitive impairment. So it's mainly people living with dementia. And again, Canada did not fare well. We have the highest rates of all countries when it came to death in long-term care.
That's wild. Yeah. I wanted to go back to something you said before about how there's, when there's that diagnosis, caregivers and the patient don't want to hear it. And like, how can we break that barrier down? Because if they don't want to hear it, then they're probably not doing anything about it. But you said that there are ways to reduce symptoms or to decrease the progression of the disease. So it's almost like with any other disease, you would, if you had cancer, you would want to know, I have cancer, I'm starting treatment ASAP. So why, other than the stigma of having that label, like why wouldn't you right away, like the next hour, start figuring out how to live with this new disease that you have?
No, it's such a good point. I think, Farah, you're the one who said it, which is like, I think when you think about cancer, you almost feel like when you get that diagnosis, you're in an umbrella of like a program that is defined to support you, no matter how aggressive the cancer might be, or, you know, whether there are treatments or not, that you're still supported.
There's like specific units in
a
hospital, but there might not be
units in hospital, but even in the community, like, you know, a close family friend of ours was diagnosed with cancer during the height of the pandemic. And within a few days, she had specialist appointments, she had follow-up appointments, someone had talked to her and the family about palliative care and end-of-life care. They had set her up with home supports, counseling, therapy, like that wraparound support is there. You don't feel like you're alone.
Absolutely.
Dealing with this thing.
Yeah.
And that's what we do with dementia.
Right.
Now.
Yeah. It's so sad
to do it on your own.
Yeah.
I've talked to people who have undergone a cancer diagnosis and treatment and then move into, you know, survivorship, where they're also kind of re-emerging from that cancer, like umbrella of care. And that is difficult for people, right? Because exactly to your point, that wraparound care has ended for them. They're cured or they're in remission from their disease. And that part is difficult, like letting go of that. And I guess it makes me think about, you know, how can we bring a sense of urgency back to, or not even back to, but how can we bring a sense of urgency to this brain health conversation? Because the more we learn, the more conversations we have like this one, you know, it compels me to want to do something and prioritize, you know, my own brain health, the brain health of my family, kind of above and beyond any other type of care, because it almost seems like, well, if we're not caring about our brains, then why are we even bothering with the rest of it? So yeah, I really want to dive into the topic of urgency around this.
Yeah. A part of it I've realized has been that we don't engage the voices of people living with disease, people living with dementia and care partners enough. They do.
Right.
And there's a lot of different reasons for why it can be hard, right? Because as that dementia progresses, the person can't communicate the same way anymore. And even if the caregiver might want to be able to communicate, there's the care that the person needs is so enormous that where would they have the time to actually come and advocate? So that's a piece, because we don't have the formal support system isn't there to support that.
Yeah.
But the other actually came up when I was speaking to an MP around dementia. And he was talking about his personal story of someone he loves who has dementia. And he said, but I don't know how to talk about that story. I could talk about cancer all day long, but I don't know how to talk about dementia because I feel like I might be taking away the dignity of that person by telling this story, because they might not like that this is where they are now.
Oh,
and this
interesting.
is what has happened.
So a lot of assumptions in the space. Yeah.
And I think my point to him, from what I've heard from people who've lived with the disease, has been they've evolved. And yes, they might not like where they are now, for sure. But they also would not like where and how they are being treated now either.
Yeah.
So you can tell the story of the person while still tying it back to who they were and who they've evolved into. And so I use my grandmother as an example, because she was a nurse, fiercely independent, but very quiet. And so it was like core of steel though. Like, with grandma, if she was going to do it, she was going to do it. And it was like nothing you could say would change her mind. And she wouldn't make a big fuss about it. She'd just do it. And that's what she did. She traveled all over the country in Sri Lanka, working as a nurse. She learned different languages, cultures, and she didn't retire. Lots of people, especially when they get married and have kids and in the 50s, and she lost her husband fairly young, people would have retired and kind of been like, okay, no. And she was just like, hell no, like this is what I do. And continued in all the way until the end. And towards the end of her life, she was diagnosed with multiple brain tumors, which resulted with all of the symptoms we've talked about just now. And I can still tell the story of what that progression was like, and tell the story of my grandma, because that's still who she was. She was still fiercely independent, and we tried to support her in that even at her end of life. And we've got to, you're absolutely right, get past the assumptions of what we think these are to be able to tell the stories, because we can tell the stories and give voice to the people living with dementia while still having dignity. The disease should not rob you of that dignity of your story. And we just equate the two. We assume that because they have the disease, they don't have the dignity anymore. And therefore we don't tell the stories anymore. HIV had to really break that stigma too, right?
Absolutely.
So much same idea.
And often a lot of people that do have dementia, they can share their stories from when they were younger. And that's what I found really interesting working there. It's like, there was this one gentleman who was a firefighter and he told me all about his time at the fire station. And there was another one who was a pilot, and like they had all of these really interesting stories. And maybe they didn't remember what my name was, or they didn't remember like what they had for breakfast that morning, but like that really didn't matter. I thought it was just really, really cool to see that despite them living in this body that they didn't probably feel like they belonged in necessarily, they still had these incredible memories that they were leaving this life with. But I also wanted to bring up because you had mentioned the restaurants and the grocery stores, but I've also seen these communities. They're in Europe, right? And I don't know the proper term for them, but do you know what the proper term is?
Well, they're called dementia villages.
Okay, dementia villages.
Right?
They're so cool. They're these concepts where, well, you probably know what they are, but it's just an enclosed community for people living with dementia. And do you think that's ever a possibility to have in Canada? I'd love to know. I guess my question here is, what does a truly inclusive future look like for people living with dementia in Canada?
So those communities, and I visited a couple of them. They're in the Netherlands, was where they first started. Yes, the Dementia Village. But there are some here as well.
Oh, okay.
So there's one that opened in Langley, I think, that is the equivalent of a dementia village. And I think the core principles behind it is that the person lives in a small home. So it's not, 25 people to 100 people in a home. It's maybe 4 people. They get up and make breakfast together. They do their laundry together. So all the day-to-day things that you would do, and you wake up when you want to wake up, not when you like at the schedule, which is
like breakfast is now.
Exactly. And I lived in long-term care actually for a couple of weeks to get that, to know that experience.
Wow, that's really cool.
It was really eye-opening. And I think staff are doing the best they can, and they have very specific constraints around how they can provide care.
Right.
But that means having to get everyone up for breakfast and into the breakfast room, like let's say by 8. And people, they need time to wake up. They need time to change and all of the health needs. So sometimes you're waking people up at like 5:36 to get them in for breakfast at 8. And that's also because they've got so many people that they have to take care of. And then breakfast might not be what they want. Or maybe you're not a morning person. Like I'm a really cranky morning person. And none of those needs are really met or considered the way we currently deliver long-term care.
Right.
So with the dementia villages, the idea is that this is your home, and so your care is, and your life is yours in terms of how that occurs. And they expanded it to have sort of shopping, like not shopping centers, sort of grocery stores and like movie theaters, and it's like big trails where people can walk, but all in an enclosed, secured environment. So they were kind of preferencing safety and trying to balance that with autonomy. But this was a really interesting thing that made me reconsider. There are advocates. Kate Swaffer is one who's from Australia, who's been living with dementia for a long time. And she has often said, well, why are we still isolating people with dementia?
Right.
So
you're still putting them away.
Putting them away. Right?
Yes.
And I hadn't thought about that, because I also was like, oh, what a fantastic model and approach to how you can provide care. And she's like, but we're not actually being inclusive, though.
Yes, that's so true.
We're still kind of isolating and segregating them, as opposed to having to adapt our environments to integrate and support people. With dementia.
Wow, that's such a good point. Could you imagine doing this concept with any other disease? It's like, I know. It's like, oh, you have
it's human rights
ALS.
violations.
Like, send you off.
It is.
Wow. Very good point.
Totally.
I just love the concept that, you could go for a walk on this trail. You could go to a cafe.
Right. It's independence that we're supporting all that.
Yes.
Absolutely. Yeah, I agree. But it takes a much bigger change. And there are movements called dementia-friendly movements, dementia-friendly communities. And Canada has several communities that have signed on to that. And that means making things just generally more accessible and training people so that they know how to interact with someone who has dementia. So like the bus driver, if a person looks like they might be lost when they get on or they don't have their ticket, knows how to respond to them and support them versus, kicking them off maybe.
Absolutely.
And so enabling that integration.
We've done quite a bit of work around understanding what it means to be patient-centric and understanding what patient centricity means. And this conversation really makes me think of some of those things, because I think that irrespective of what we call it, right, whether we're actually using the words patient centricity or not, ultimately what it means for people is that we all feel seen, heard, valued, and respected. And I think that so much of what we've learned today during this conversation is that a diagnosis of dementia does not change change any of those things, right? Even a person living with dementia is still worthy of being seen, valued, heard, and respected. And I think that as you've shared your examples and your stories, it's really reminded me that some of these things, when we think about being inclusive or being, building dementia-friendly communities or facilities, that's what it's really about. We all just want to feel like we are part of something, that we matter, right? That our voices are heard. And we shouldn't be thinking about this as completely separate and independent from that. And that's what it's really reminded me of and made me think differently about that. And Saskia, I love that the stories that you shared, not just about the people that you've encountered in your work, but really how the work you're doing now was inspired by your own stories and your own personal experiences. And that's what, those are the conversations that we've really been so inspired to talk about and to share, because we know that stories transform, right? Stories change and stories create positive change. And we've loved listening to yours.
Yes.
Oh, thank you.
Yeah.
Thank you. The stories inspire others and they shape us. And I think if we all look back far enough, there have been key stories, consciously or unconsciously, that have shaped how we think about ourselves and the passions and the purposes that we find.
Right.
Right. And ultimately, we all want to lead lives that have purpose and that are valued.
Yes.
People living with dementia want to do the same. And that's really all that we hope to be able to achieve collectively, no matter what disease or health condition you're living with.
And before we wrap up the conversation, I'd love to just hear the story about what your experience was like living in a long-term care facility. Did you do this for research purposes?
Kind of yes and kind of no. I remember my PhD thesis supervisor, I was looking at how do people living with dementia interact with the health system, like just throughout a long trajectory, like over 10 years. Where do they go? How do they move through it? And are there like certain points that are like trigger points that we could use to then map and support them better? And then I went to speak to Kim McGrail, was my supervisor, and she's an amazing mentor. And I was like, I feel like I'm just still not getting the full understanding of this, because so many people do end up in long-term care when you're living with dementia towards those end stages. And so I said, I think I need to go check myself into a long-term care home. And she was incredibly supportive. Afterwards, she was like, I have never had anyone say that that's what they want to do. But again, when you live that experience is when you can really appreciate where it comes from, right? And there's lots of examples around that where executive staff at long-term cares have been told that they have to eat their lunches and breakfasts and dinners in the home. They're not bringing their own food. And all of a sudden, the quality of the food changes because you're now eating this food and you're like, oh my God, like this is not how I would want to eat. Why is it okay for us to provide this to a resident who lives here?
Yeah.
So it's the same thing with long-term care. And so I lived there for a couple of weeks in 2 different homes. One was an urban home, like sort of in the middle of the city. And the other was a brand new purpose-built home, but further away.
Okay.
And I kind of wanted to get a sense of what does that feel like? And in both cases, like the staff were phenomenal, but the things that really triggered for me the thoughts was around how clinical the care is. So in the first home, when I moved in, they said, you can't have anyone visit you and you can't leave for the first few days, because that's what we would normally do with the resident to make sure that they are oriented to their home and they feel this is home and they don't get agitated.
Wow.
Which was already, I was like, oh, like, okay.
I can't
That
leave.
seems like it would cause lots of agitation.
Yeah, that would be.
It was very interesting that was the policy at the time. And then when for the first 24 to 48 hours, they come in to check on you every couple of hours, all through the day, like including at night. So someone would come and wake me up at like 2 a.m. to check my blood pressure, check my temperature, check that I don't have an ill. And so again, I was like, clinically, I get it. Like if you were in a hospital and this is exactly what you would do, because you're wanting to make sure that the person doesn't have an infection when they come in. They need to be taken care of. But from like a person-centered perspective, you're waking this person up 3 times in the middle of the night, plus throughout the day. Like it was not, we had not thought through the person. We were thinking about it from the medical clinical care.
Yeah, which it's often, that's where people are, what people are doing in healthcare.
That's it.
Yeah.
And that's because long-term care was built on a medical model, basically. It's not built on a home model per se.
Right.
The other thing that really stood out for me was like, I missed breakfast on one of the days. And they said, okay, we can bring a tray into you, but a staff member has to stand here and watch you eat.
Stand.
Oh, stop.
To make sure that you didn't choke or, that you were swallowing all right.
Which I understand, but could it be like, have a tea with the person?
Correct.
Yeah.
That's my point. Yeah, totally.
Yes.
But no, like the staff person stood and watched me eat and wouldn't talk to me because they were also frustrated because they had like all these other, residents they had to take care of, but now they had to like add this extra time to watch me eat. So there were so many little things where we were prefacing safety and clinical care over the person and autonomy and supporting independence.
Oh, yeah.
And that was really...
Just like totally infantilizing the person, right?
Exactly.
Yeah.
And I think that was what really struck for me, how much long-term care could evolve and should evolve. But that's also where those dementia villages really demonstrate the point of being able to provide good care without necessarily having to infantilize or take away the person's independence and autonomy.
Right.
Yeah. Interesting. Well, if there's one thing that you would want policymakers or just anybody in general to take away from this conversation around brain health and dementia, what would that be? I know there's probably more than one thing.
Like,
and like
there are about 35 things.
And we've like talked a lot about,
did.
but just to reiterate.
I'd say 1 in 3 Canadians know someone living with dementia. That means that you're going to be caring for someone living with dementia, or you know someone who is caring for someone living with dementia. So this is not a disease that is not going to touch you.
Right.
It is. And it is a public health disease because it is not just health. It is driving, it is community housing, it is all of these other things. And if we don't tackle it now, we're going to have a super aged population of adults whom we are not going to be providing good care for, and it is going to become a huge, I mean, even economically, a huge economic drain, because direct care in hospital is where people are going to go. They're going to go to the ER because there's no other place to get care. Yeah. And that is not where you want someone living with dementia to be going for care. A, it's extraordinarily expensive, at least 5 to 10 times more. But B, it's the wrong use of the resource, and the person declines often further. They have poorer outcomes in hospital. So we need to coordinate how we provide this care for dementia, because we've done it for other diseases and we can definitely do it for dementia. The templates are there, but we need to have the political will to do it.
Yeah.
So if people want to work with you, can they go to your brain health website? Or
absolutely.
Or not brain health.
Yeah,
Brainwell.
the Brainwell Institute.
Brainwell Institute.
Yes, absolutely. We have a sign-up page where if you're interested in advocating, sharing your story, we are looking at bringing people together to be able to really speak to policymakers and share this information. We've also really engaged on a social media level, because that's another really fantastic way to share stories.
Absolutely.
So you can follow us on all of those, and we do share a lot of the more recent evidence around brain health that you can practically put into use, because that's the other piece, right? There's not much value if you can't use the information.
Yeah, exactly.
Yeah, absolutely.
Yeah. And we'll link all of the links in our show notes, so people know where to find you.
Thank you.
Yeah, thank you.
Thank you. We applaud you for the work you're doing in this space, for really bringing, incredible expertise and experience to a space where I think, more voices, louder voices are absolutely needed. So thank you so much for sharing your story with us today.
Yeah. And thanks to your parents for not, diminishing those whys, because it just, when you shared that story, I was like, you know what? I'm going to just keep answering all those whys from my kids, and maybe they'll be future Saskias.
Yeah, you never know. Certainly future researchers.
Yes. Thank you.